Good evening, everyone. I am Harsha from Science Integra, and today I extend a warm welcome to all of you for the 22nd episode of webinar called Maha Smiles Cleft Care for Every Child. So, this is event organized by AMOX in collaboration with Smile Train India and the Public Awareness Committee, FOXY, with the aim of raising awareness about the cleft lip and palate conditions in children. So it's my pleasure to introduce Miss Leela ma'am, who is the Senior Director of Education Training and Comprehensive Cleft Care Programs at Smile Train India. Over to you, ma'am.
Thank you, Harsha. A very warm good evening to all of you. I don't know how much you know about the Smile Train, but we have been conducting this webinar regularly. So I just wanted to inform you that Smile Train is the world's largest cleft charity. And we've completed 25 years in India. And over 25 years, we've completed more than 7,75,000 surgeries. And we have about 13 partner hospitals in Maharashtra. Our Maharashtra program is very large. We're very proud of our Maharashtra program. And in Maharashtra, in last 25 years, we have uh, performed with the support of our 13 partner, 57,000 surgery. And our major partner today, Dr. Lahane, is here with us. And we are having this webinar under the aegis of Bajaj. They are our major supporters. So this has webinar. We have taken this initiative. It's called Maha Smiles. And in under Maha Smile, our logo is the cleft care for every child who's born with a cleft. And this is supported by Bajaj Finserv. So under this program, so this is like I mentioned, this is a flagship CSR collaboration with Bajaj Finserv. And it is aims to build awareness and support the treatment of children born with cleft in the state of Maharashtra. Maha Smiles will enable about 8,000 life transforming cleft surgery in children needed in Maharashtra in a period of last 36 months. And the main objective of this Maha Smile program is to create awareness about the timely treatment and the timelines of the cleft treatment. Like when the child is born with the cleft, when he should go for a surgery, because when the child is born with the cleft, there are multiple surgeries are involved, there are multiple rehabilitation is involved, there is a nutrition involved, speech involved, orthodontic involved, and there is finally the orthognathic surgery involved when the child's facial growth is complete. That is done generally after the age of 16 or 18 years, and that we consider is a final surgery in the cleft care. And another objective was to build a referral network so that the children can avail care for the children who are born with the cleft. So if you've seen, because the main idea of collaborating with Foxy and Amox is that, because when you do come across children who are born with the cleft, so, by having a partnership with you, our objective is that to raise awareness and, to refer that to the right places. Like you work very closely with radiologists. So the radiologists, they would know where to, refer the child who's born with a cleft. So if you see, we have another toll-free number. We have a toll-free number which is also supported by Bajaj, and that toll-free number is 1-800-103-8301. So anytime you come across a child who's born with a cleft or anyone who knows a child born with a cleft, please get in touch with our helpline number and we connect them to the right hospital. As you can see from the map, we have 13 hospitals, but our coverage is not so great. Like we are working on the ground. So if you see our partner hospital, they travel wide, because through their coordinator and their teams, they go and perform a lot of, camps and get the patient and perform the surgeries. So we do have a 13 partner hospitals. And we rely on your goodwill and your reference system to ensure that every child who's born with a cleft receives the surgery and is a productive member of the society. So back to you, Harsha.
Thank you, Leela ma'am, for the inauguration. We the first President, Dr. Amay Purandare sir, and he is also the Joint Treasurer of Foxy. Sir, this is the 22nd episode in line, and this has been continuing since Dr. Pardeshi sir's tenure. So we would request you for your words of wisdom and blessings for this program, sir.
Thank you, Monica, for having invited me as chief guest for this very important webinar. I feel very satisfied on one side because, as Leela ma'am would know, our partnership began in Dr. Nandita's year in Delhi in 2019, and that partnership has grown even greater. It further got amplified when we had the Maha Smiles under Dr. Pardesi's tenure, for which I was very happy that the Smile Foundation, as always, put forward their hand to collaborate and with AMOGs, where I was able to bridge this partnership. So, over 6 years, I think a lot of work has been done. But like Leela ma'am said, we have still not finished our journey. We had that time pledged that every child born with cleft, we would ensure the best and optimal outcome by providing all the support, not just surgical, medical, but also family and financial. And I think our dream will come true when obviously we are able to provide every child with cleft the best possible outcome. I think we began the journey by encouraging a greater awareness to detection, that is by imaging. A lot of our stress was on imaging. With better technology, we are able to diagnose, detect, and prognosticate cleft anomalies with excellent ultrasound, especially the contour based ultrasound. Not only that, surgery also has been refined and become much more accessible, affordable, importantly, beneficial to these children with cleft. So I think we are doing our best, and I hope this partnership grows from strength to strength in the years to come. I'm sure that it is going to be an integral part of my tenure as well when I take over in the forthcoming March. And I think that we will add on to many more dimensions to this problem. I congratulate Monica and the rest of the organizers and the technology partner Integra for organizing this persistently and putting in all the hard work and sincerity towards the efficient organization. Last but not the least, this would not have been successful without our friends from various faculties, the plastic surgeons, the radiologists, the counselors, the pediatricians, because I think it's not a single person's efforts. It's going to be a multidisciplinary effort, and each one of us has to put in their part in a united way to ensure that the best can be done for the child. So, once again, thank you all the friends from all the specialities for collaborating with us. Last but not the least, I wish all my Amoxians take benefit of such webinars so that we can spread awareness, assure the patients, and ensure that every child has a smile which is not just beautiful, but it is long lasting via this project. Thank you so much, Monica.
Thank you, sir. Thank you so much. And we wish to continue this in your tenure also, sir,
Yeah.
as
So,
President of. Yes, sir. Thank you so much for gracing this occasion and accepting our invite for today. Dr. Preeti, I would like you to introduce Dr. Lakshmi Srikhande, madam.
Thank you. Thank you so much, Monica. Can we have the slide deck, please? Thank you so much, Amaya. And I think that was very true. And I mean, before I was a part of Smile Train, and thank you, Monica, for making me a part of Smile Train. Even I never knew how much work goes behind, doing this thing for these special children with cleft lip and cleft palate, and how, I mean, we as gynecs need to work so much to make that happen. And I think that awareness that you are trying to spread, Monica, I mean, 3 years is really long. The consistency that is required and the committee, the commitment that you have is amazing. So I have the pleasure of introducing Dr. Lakshmi Shikhande, madam. Dr. Lakshmi Shikhande is has been the ICOG chairperson in the year 2023. She's the medical director of the Shikhande IVF Center and the Fertility Clinic. She's the national corresponding editor journal of Jogi, national corresponding secretary for the AMWI, and the joint secretary of the Indian Menopause Society, has been the past president of Vidarbha Isopap Society as well as the IMS Education Committee. I think Madam has a long list of things that Madam has achieved. She has been the president of the Menopause Society in 2016-18. I know I have been to Nagpur when Madam was, I think, the senior president there with Dr. Suchitra Pandit Madam, and we were like I mean, she was such a gracious host. And thank you, Madam. Madam has been awarded the FRCOG from UK, has also got the Nagpur Ratan Award at the hands of Nitin Gadkari Sirji, has received even the Bharat Excellence Award for Women's Health, Best Committee Award as a chairperson of HIV/AIDS Committee of FOXY in 2007-9, has been doing amazing work in Save the Girl Child project. So welcome, ma'am, and thank you so much for gracing the occasion.
Thank you, Preeti, for such kind introduction. Very good evening, everyone. I'm really very, very happy to be part of such a wonderful and great project started by AMOX with the Smile Foundation. And as Ame has already told that this project is consistently going on from last 6 years. So I will also add to Ame's words that consistency really matters. And with the cleft lip and cleft palate, as he has said, with advancement in the imaging technology, more and more congenital anomalies are being picked up, and cleft lip and cleft palate is one of them. Not only radiologists, but many gynecologists, they also diagnose. And nowadays, we are having so many fetal medicine specialists who are also doing these imaging technologies. So they are also picking up this cleft lip and cleft palate. So Leela, I mean, you must spread out that helpline number to all the gynecologists and to all the fetal medicine specialists along with the radiologists. Rather, I will say to all the lay people as well, because many parents with cleft lip and cleft palate, they might not be diagnosed when they are under the banner of AMOX or FOXY. If they are diagnosed under rural area or they are really very poor. So if you spread out that toll-free number freely to the masses, I think if they are having a child who is having cleft lip or cleft palate, they can call on that helpline number and you can actually reach out to the beneficiary. This is just one suggestion from my side. And yes, Monica, you are doing a wonderful work. And thank you for making me a part of this wonderful initiative. And I am also eagerly waiting to listen to Dr. Wasim that what is the embryological aspect of cleft lip and cleft palate, and Dr. Lahane. So nice to note that you are offering this plastic surgery to these babies. And also, Leela, you must stress out that now plastic surgery is a wonderful, I mean, gives a wonderful outcome to the baby. I mean, nobody can even make out that this child once upon a time suffered from cleft lip and cleft palate. So this second thing also we should spread out to the masses. We gynecologists know, we doctors know, but the parents, they should know that once their child is being diagnosed as cleft lip and cleft palate, they should not go and abort. The outcome is fantastic provided they are under control. I mean, they are in the supervision of expert hands. So thank you for inviting me. And Monica, please go ahead. I am handing over back to you.
Yes, sir.
So I
Thank
just
you so
wanted to
much,
comment
ma'am.
for a minute away,
Yes, ma'am.
Dr. Monica. Dr.
Yes,
Lakshmi,
ma'am.
thank you very much for our appreciation and your recommendation. So we have been working with lot with ASHA workers because they are the ones who come to know when the child is born with a cleft, and we hope to work very closely with the government hospitals also in Maharashtra. Because we have AMOX covered, but there are the partner, the government hospital where these deliveries do happen. And another one is a radiology because every child every mother who's pregnant goes through the has to go through a scan. So that is the time, and there are cases, Dr. Nahane will talk about it, when the mothers are referred to our because they never heard about cleft, and when the radiologist tells them the child is going to have cleft, and then they visit our centers, and that is the time a lot of psychosocial aspect of our work kicks in. When we tell them, look, this child was born, and this is what happened, and this is what it is, and we are there to take care of it. But we can only advise and recommend. The final choice is they have a right to have make a choice. But yes, you are right. We need to publicize. We have been doing publicizing our toll-free number, and we do get calls from everywhere. Sometimes the child is abandoned. We see someone sees a child on the road and calls us up. I saw this child. Like, so it is happening slowly and gradually. Idea is to create awareness, and that's why we have a tie-up with you. So thank you so much, Dr. Lakshmi. Back to you, Dr. Monica. Thank you very much.
Thank you, Lakshmi ma'am, for gracing the occasion and wishing you all the very best as a candidate for representative to for Foxy for your elections. I'm sure all among society would definitely support you. I would now introduce Dr. Sujata, our next guest of honor for today. She is the editor-in-chief for Jogi, and she has been the past secretary of AMOX. We welcome you, ma'am.
Yeah. So, Monica, thank you
Yes,
for a
ma'am.
very short and crisp introduction. I don't want a long introduction. But to start off with, I would like to express my gratitude to the AMOGS because this project was started when Dr. Pardesi was the president, and that was at the end of his tenure, about just 3-4 months to go. And he got this good proposal and he immediately accepted it. I was a secretary at that time, and we thought it was of a great benefits to AMOGS, but not only to AMOGS, but also to create awareness among all the Amoxians all over. And that is the reason we immediately accepted and this project was started. And I'm happy to know that this is some 22nd or 23rd episode. For that, I would like to express my gratitude to Dr. Monica Umbadan. And of course, Supriya is also a convener of this program. And of course, AMOX president and the whole team AMOX for continuing this program, because this program is of such an immense importance that it has to bring about smile to the children who are having this cleft lip, cleft palate problem. Reiterating one case, nowadays this is being diagnosed on a sonography. I had one couple who had come to me at around 14 to 15 weeks saying that baby is having this and they wanted to terminate the pregnancy. When I told them that this is not a major anomaly that you need to terminate, they went and took a second opinion, and there also the same thing came, and they insisted on termination of pregnancy, and I had no other choice but to terminate the pregnancy. So much awareness is there so far as the urban population is concerned, but we need to bring about awareness so far as rural population is concerned, so that everybody is aware of the same. At the same time, also they need to know that this is one thing which can be correctable, and we have our collaboration with our NGOs who are willing to help them and who are willing to do this surgery free of charge to the needy patient. I'm sure today's speaker, whatever knowledge that they're going to impart, the listeners or the delegates who are listening to the today's talk will be able to implement the same so far as the clinical practice is concerned. My best wishes to Monica and Supriya for their future endeavor in Foxy, and of course to my co-guest of honor, Dr. Lakshmi, for a future endeavor in EOFOC. And I would like to reiterate the words of wisdom given by our Vice President Dr. Amaya Purandare. So far as today's program is concerned, my best wishes and loads of success to the program. Thank you so much.
Thank you so much, ma'am. Ma'am, you forgot me.
Oh yeah.
I was
That's
just
because
about
Monica introduced me, so I was wondering maybe you have disappeared somewhere.
No, no, I'm very much here, ma'am.
No. Best wishes to Preeti also. She has been working very hard, and I'm sure they will all have a good success so far as Fox's endeavor is concerned.
with all your support, ma'am. Thank
Yeah,
you so much.
definitely. Anytime and always.
Yes, ma'am.
Thank you.
Thank you, Amay sir. Thank you, Lakshmi ma'am, and thank you, Sujata ma'am, for accepting our invite and being there. So I announce that the inauguration is over. And Harsha, can we have the prayer song so that we can start with the academic session, which Dr. Preeti will be chairing.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
Okay. Thank you so much, Monica. And I think now we can start the official academic program. So to have our first speaker is Dr. Wasim, and I'd like to invite the three chairpersons. Dr. Neha Lad, Madam, is the president right now, just newly elected, of Nashik OBGYN Society, has been the past clinical secretary as well as the VP before that of the Nashik Society, and the treasurer of the Western Maharashtra chapter of IFS. She's a fertility and IVF consultant at Lad's Navjeevan Hospital and has received multiple awards, including the Vasantrao Gupte Award of Best Doctor in 2002 and the Sahyadri Puraskar. Also the MS Signature International Award of Hirakani Award, the Dronacharya Award of ISA 2024. Welcome, Madam. We also have with us Dr. Yogi Raj. Dr. Yogi Raj Chidre is a senior consultant at Suvedya Maternity Home, the president right now of the Udgir OBGYN Society, and is known for his surgical expertise, academic presence, and extensive community outreach. Beyond the clinical duties, he is a very, very strong leadership in the regional medical societies and is the founder for the Udgir Society, contributing to all the AMOGS initiative. Welcome, sir. We have with us Dr. Shweta Kaul Jha. Dr. Shweta Kaul is a director of the Nirabai Care Women Center at Indore and right now the vice president of the Indore OBGYN Society. Specialist association would be managing committee member of ISAR, the joint librarian of the MP chapter of ISAR and the managing committee member of the MP chapter of IAG. Is also the executive member and convener of the infertility committee of AMPOJS as well as the state coordinator for the FOXY midlife committee in 2022 to 24 and also the infertility from 24 to 26 onwards. So welcome, madam. Again,
Thank
Dr.
you.
Shweta is a winner of multiple awards, including the Dronacharya, including the B.N. Roy, which is a very prestigious gold medal award for the all-rounder best student at the MBBS.
Thank you.
Welcome, Dr. Shweta.
Thank you.
Can
Thank
I
you.
please request Dr. Shweta or Dr. Neha to introduce our first speaker, Dr. Vasim.
Dr. Neha is there?
No, I think she was a little busy in her
Okay.
procedure. If you can take over.
I'll introduce.
Thank you.
Yeah. Thank you. First of all, I would like to thank Dr. Monica, Dr. Supriya, and Team Ampox for giving me this opportunity to be a part of this August gathering. And it is my And I will put in a word that a lot of work is done by Smile Train at my native, the place where I'm working, Indore. I'm sure Leela madam must be knowing about it, and Dr. Jaideep Chavan is heading. A lot of work is being done under Smile Train at Indore. So it was very interesting to join this webinar, which covers the same topic. So Dr. Wasim Hiroli is a MD Anatomy and he's assistant professor, Department of Anatomy at Dr. V.M. Government Medical College, Sholapur. And he has published articles in various national and international journals and edited articles from Perspective in Medical Science publication. So we are very happy to have you, sir, here to discuss the embryology part of the cleft lip and palate. Over to you, sir.
Thank you, ma'am. Thank you for introducing me. And thanks for giving an opportunity to have a lecture on the development of the cleft lip and the palate. I'm sharing the screen. Shall I?
Yes, sir.
Is it visible, ma'am?
Yes, it is visible. You can open your PPT.
Okay.
Yeah.
Just a minute. slideshow from beginning. Okay. Let's stop sharing. Okay. Visible, ma'am, please, all of you.
Yes.
Yeah, the slides are visible, sir.
Thank you. Thank you. So, to be given my introduction, myself, Dr. Vasim, Assistant Professor, Anatomy Department, BMGMC, and I'm going to talk on development of the lip and the palate. Okay. So, as the cleft lip and the palate, it is the second most common congenital anomaly after the club foot. Now, there are almost 15 types of orofacial cleftings are there, of which the cleft lip and the cleft palate is the most common. So hence it is important to study the development of the lip and the palate. Now coming to the epidemiological background, let us see. Worldwide, you see the incidence, it is 1 in every 600 to 800 live birth, while the cleft lip with or without palate, it goes around 9.92 per 10,000 live birth. If then cleft lip alone, it is 3.28 per 10,000, while the cleft lip with palate, it is 6.64 per 10,000 live. So this is the incidence worldwide. Now coming to the India, in India, the meta-analysis of early studies show the incidence of cleft lip and the palate is approximately 1 in every 781 live birth. In India alone, the number of infants born every year with the cleft lip and the palate, they are approximately 28,000 to 35,000. Now, if you see the 78 affected infants are born every day, or it can be seen as 3 infants with the cleft are born every hour. Now, some common facts about they are mostly the most common. They are unilateral on the one side, and they are common on the left side. While comparing the male to female ratio, it is nearly about 2:1. Now the males are more commonly affected by the cleft lip, while the females are more commonly affected by the cleft palate. So these are the common facts. Now coming to the causes, it may be the genetic, it may be the environmental, or it may be the multifactorial. As the genetic disorder have been classified into the 4 groups. The one is chromosomal, second it is a single gene inheritance, then next one it is multifactorial, and last one it is mitochondrial inheritance, of which this cleft lip and the cleft palate, it belongs to the multifactorial, where various factors other than genetics, the multifactorial environmental factors, they are contributing to the development or causing the cleft lip and the cleft palate, since it is multifactorial. Now, some of the characteristics. The chance of cleft lip and the cleft palate, it increases if more than one family member is affected. More the severity depends that whether it is involving the lip, the alveolar arch, or the entire palate. So more the severity, greater the chance of the recurrence in the siblings. And the risk decreases in the remotely related individuals. Now, the consanguinity marriages, they increases the rate because of sharing of the affected genes. Now, some of the environmental factors, like the most common, the drugs. The first one, it is the phenytoin. The second, it is the most important, it is vitamin A. Vitamin A analogs such as isotretinoin, some corticosteroid drugs, and the anti-inflammatory drugs. Other than that, rare smoking, consumption of the alcohol, viral infections, and poor nutrition, they may lead to some of the. Now, let us see the prediction of the risk. There may be affected, unaffected parents, or maybe the child. Now, what are the risks for the cleft in the coming offspring. When both the parents, they are unaffected, while they have one affected child, the chance of risk of having the cleft in the offspring, it is 4.4% for the cleft lip and the cleft palate, while it is 2.5% for cleft palate only. When only one parent is affected, the chance it is 3.2% for the cleft lip and the cleft palate, while 6.8% for the cleft palate only. Now, another possibility that one of the parent is affected, having the one child is having the cleft lip or the palate. The chances increases the more, the risk is more, for that is 15.8% for the cleft lip and cleft palate, while 14.9% for the cleft palate only. So these are the risks for the cleft in the offspring, depending upon whether the parents they are affected, unaffected, or maybe the having the child being affected. So these are the prediction of the risk. Now let us come back to our the main heading today's, that is embryological background. Now moving on to, this is the right side, there is a picture showing the lateral view of developing embryo, where it is in the 14th somite stage, showing the appearance of the first two pharyngeal arches. Here this is the first and the second pharyngeal arch, which is showing its appearance at the 14th somite stage, and they contribute. Now these pharyngeal arches, they not only contribute to the development of the neck, but also they help in the formation of face. Now, each pharyngeal arch. Now, what does this arch contains? The first one, it is the core of the mesenchyme and also the migrated neural crest cells from the hindbrain. Now, outerly, this pharyngeal arch having a covering of ectoderm, and innerly it is having a covering onto the right, showing a section of the developing embryo, where this is the neural tube. Okay. Now here, this is the arch having outerly blue, that is line, this is ectoderm, and innerly yellow color, it is line, that is endoderm. So in between those two arches, on inner aspect, there is a pharyngeal pouch of endoderm, while on the outer aspect, there is a cleft of ectoderm. Now, in this figure, there is increase, or there is the number of pharyngeal arches appears, it is shown. Altogether, there are 6 pharyngeal arch which extends. So this is the cranial end, this is the caudal end, this is the somite. Here, there are 2 pharyngeal arch, the first and the second, while subsequently, as they develop the number of arches, they increase and they become 6 in number. So this is the dorsal border and this is the ventral border. So this pharyngeal arch, it extends from here, this is the hindbrain, to the mid-ventral line, where these arches, they meet. Now they extend. Now this is the cranial end, this is caudal end. Now another bulge below the second, this is a bulge, cardiac bulge or heart bulge is there, and in between there is a space. In the subsequent we will be seeing. So they extend just below the stomodium. This is the opening is there. There is developing pharynx, primitive pharynx is there. So this pharynx, it is covered on its lateral aspect, while the floor of the pharynx, it is being covered by the arch. This is pharyngeal arch. The 5th one, it disappears. Now, at the end of 4th week, the center of the face. So here, this is the cranial, this is the caudal end, this is the developing face will be there. So in the center of the face, there is an opening or there is an depression is there called as stomodium. And this stomodium, it is cranially bounded by frontonasal process. Laterally, here we have the pharyngeal arch, mainly the maxillary prominence and the mandibular arch, which is coming from the first arch. Caudally, there is a bulge of developing heart. This is called as heart bulge. So these are the boundaries of the stomodium. what is frontonasal process? There are two figures out there. On to the left, this is the developing embryo at the 28th day. And here there is a schematic diagram. The fronto here on the right, here you can see there is a hollow tube is there. This is a neural tube. Now this is a vesicle called as forebrain vesicle. This is here will be the midbrain and the hindbrain vesicle, and this is the caudal narrowest part. Okay. Now this is the outer one. This is the ectoderm, and in between the two, here it is. This here contains the mesenchyme. So the mesenchyme, which is going to cover the caudalmost part, this is the forebrain vesicle. It is covering the caudal part of the forebrain vesicle along with the ectoderm. This is called as frontonasal process. So this is the first process. Okay. Now the second one, as it has got the first arch, which is called as, mainly it is called as mandibular arch, but this arch, it divides and it gives rise to two processes. The one is maxillary prominence and another one, it is a mandibular process. So these both, they are coming from the first arch. Now as this contains the mesenchyme is there, the mesenchyme of the pharyngeal arch, they are coming from also the neural crest cells. Now these are the neural crest cells, they are migrating. On to the left, there is a diagram showing the midbrain, and there is a hindbrain is there. Okay, forebrain, midbrain, and the hindbrain. These R1, R2, R3, we will be dealing in the molecular genetic basis at the time. So these are the three parts. Now from these three, the neural crest cells, they migrate, that is to the frontonasal process. So the neural crest cells from the forebrain and the midbrain, they will be migrating around the FNP, nothing but it is a frontonasal process. While the neural crest cell from the hindbrain, they gives rise to the mesenchyme of the both. Now here just below there is written MDP, okay, MXP, that is maxillary process, and below there is a mandibular process. So both these processes, they receive the neural crest cells mainly from the midbrain and the hindbrain, and they will be forming the. Now this is the morphic, that is the basic morphology of the face is mainly established between the 4th and the 5th week of the development, and they are mainly contributed by. So on to the right, it is mainly contributed by the frontonasal process. Then it has got the maxillary process, and the next one, that is a pair of mandibular process. Altogether 5 processes they are contributing, and all these 5 prominences, that is frontonasal prominence, maxillary prominence, and the mandibular process, they make its appearance at the 4th week, end of the 4th week. Now this is an opening or a depression, which is more separated from the gastrointestinal tract innerly by an oropharyngeal membrane or buccopharyngeal membrane. Now during 6th week, what happened? Now this is a diagram showing. Here it is the this is the frontonasal process. Okay. Now below here, this is the first arch where can be seen. The green color, it denotes the maxillary process, while the blue color, it shows the mandibular process. Now as go on to from A to B and C, as it grows, the growth occurs, the maxillary process, it enlarges and it grows ventrally as well as medially. Simultaneously, there can be seen in diagram A, on either side of the frontonasal process, there are 2 thickenings are there. These are nothing but these are the ectoderm, it undergoes a thickening to form a placode. This is called as nasal placode, or is also called as olfactory placode. Okay. Now these placodes are formed, they undergo, these are the ectodermal thickenings. Now in the 6th week, this ectoderm of each nasal placode, it invaginates into the underlying mesenchyme, okay, to form a pit, that is a depression, which is called as nasal pit, or you can call it as a nasal gutter. Now why does it happen? It happens due to whatever the frontonasal process is carrying the mesenchyme, there is overgrowth of this mesenchyme around the nasal plateau, ultimately converting that nasal pit into the gutter or the nasal pit. And in this way, the nasal pit in the diagram here, the B here you can be shown, that is in the center there, the nasal pit or the nasal gutter that divides the frontonasal process into two parts. The one, it is called as medial nasal process, which is lying between the two nasal pits, while lateral to the nasal pit, that is a pink color, this is a lateral nasal process. So these processes are formed on and around the 6th week of the development. Now this is a picture. Here it can be seen. Here it is the frontonasal process is there at the cephalic end, while just below it, here can be seen the thickening of ectoderm, that is nothing but the nasal plateau. Okay. Now these nasal plateau, it further deepens, and the mesenchyme surrounding it of the frontonasal process, it is being divisible into two parts. The medial, it is the medial nasal process, while lateral, it is a lateral nasal process. Now, coming at 5th to 6th week again, here, this is the lateral nasal process. Between the lateral nasal process and the maxillary process, there is a one groove is there, and this groove, it is called as nasolacrimal groove, also called as naso-optic furrow. Now, during the 7th week of embryonic development, the ectoderm, in this here it can be seen, here it is the lateral nasal process, and this is the maxillary process. Now, as the lateral nasal process, it moves towards the lateral nasal process. Now what happens? The ectoderm at the floor of this groove, it invaginates into the underlying mesenchyme, and these mesenchyme, it proliferate to form a solid ectodermal cord, and these will be forming nasolacrimal duct. Now in this here, there is a figure A to the right, B, C, and the D. While this blue color, this is a lateral nasal process, below it is a maxillary process, and here it is shown the invaginating ectoderm. This invaginating ectoderm, it proliferates, it grows to form a solid cord of ectoderm. Later on, again it proliferates further. There is the cells of these solid cords, they undergo the canalization, resulting in formation of a hollow duct. Now, this duct, it has got two parts are there. The one at the top, here, it will be forming the lacrimal sac, while the lower part of this duct will be forming the nasolacrimal duct, which will be opening into the inferior nasal meatus. Now, followed by this, the cord get detached, and soon the ectoderm of this maxillary process and the lateral nasal prominence, they merge with each other. Now, coming to the development of upper lip. Now here, there is a medial nasal process. It is shown on medial to this nasal pit. Now these two nasal processes, they move towards each other, that is towards the midline. Also, in the second diagram, that is the D1, it is shown the inferior extremity of the medial nasal process. It expands or it grows laterally and somewhat medially, and they fuse in the midline to form a segment, and this segment, it is called as intermaxillary process. This intermaxillary process, it gives rise to philtrum, that is a part of upper lip, alveolar arch, that is premaxillary bone, which is containing or having the 4 incisor tooth holding it. And last one, it is the posterior most part, it is the primary palate, which will be dealing with the development of the palate. Now, thus the upper lip, it is formed by 3 elements. Here it can be seen. The middle one, it is the labial part of the intermaxillary. Here it is green color shown, intermaxillary process. So this is the labial part of intermaxillary process. While the yellow colored, it is showing the lateral part of maxillary process. It will be forming the lateral part of the upper lip. So the upper lip is contributed by two things. The one is labial part of intermaxillary process, and also the lateral part of maxillary or maxillary process. Now development of the lower lip. Here, this is the orange color structure, the caudal most, the caudal to the maxillary swelling. There is a swelling called as mandibular swelling. The two swellings, these are the two in number. In the middle, it shows a fissure. So these two mandibular swelling in the initial phase, it is being separated from each other by mid-ventral. There is a fissure is there. But as later, it continues with each other like other pharyngeal arches. They continue with each other. These are the mandibular swelling continue with each other, forming the lower lip. Okay. Thus, the lower lip, it is formed by fusion of the two mandibular swellings. Here it can be seen in the last picture. So this is the orange color forming the lower lip, as well as other contributing you will see later. This is the chin will be there, lower part of the cheek will be there, and the lower jaw. All these things will be contributed by the two mandibular arch. Now, if see here, the black color, that is a fissure is there, the oral fissure. Initially, oral fissure nothing but it is the fissure between the maxillary prominence and the mandibular process. So initially they are the lateral angle between, that is the angle between these two arch, it is reaching almost close to the auricle. But with the fusion of these mandibular process and the maxillary process, the angle, it is reaching to its adult position, that is shifting to the medially, that is close to its adult position. Also this fusion resulting in formation of the cheek. Now this is a schematic diagram showing the derivative of various processes. The frontonasal process is mainly forming the forehead and the bridge of the nose, while the maxillary process, it is going to form the upper part of the cheek, that is lateral part of the upper lip will be there, also contributing to the premaxilla, which is holding the four incisor tooth, as well as the primary palate. Now the mandibular process, it forms the chin, the lower lip, the lower jaw, and the lower part of the cheek. So this will be formed by the mandibular process. Now there is medial nasal process. This medial nasal process, that is labial part, it contributes to the philtrum, which is the median part of the upper lip. So this is a little bit theoretical. So the frontonasal process, it is mainly contributing the forehead and the nasal bridge, while the medial nasal process, it forms philtrum, premaxilla, primitive palate, and the tip of the nose. So on to the right, here it is shown, this is the maxillary process, and in between the middle, this is the intermaxillary segment, which is coming from the medial nasal process. So it has got three parts. Now the lateral nasal process, it forms the ala of the nose. Now the maxillary process and the mandibular process, maxillary process, it forms the upper jaw, lateral part of the upper lip, upper part of the cheek. And the mandibular process, it forms chin, lower jaw, lower lip, and the lower part of the cheek. Now we are finished with the development of the face. Now coming on to the formation of the palate. The palate, the development of the palate is mainly contributed by two sources. The one you called it as a primary palate, and another it is called as secondary palate. Now here, this is intermaxillary segment. Now this intermaxillary segment, it has got three parts. The first one, this is which is forming the philtrum of the lip. This is nothing but this is the labial part. Now this is the middle portion which is holding the four incisor tooth. you called it as premaxilla. And the last one behind it, this is the third part. This is the palatal component, which will be forming the primary palate. So these are the three structures are there. So this primary palate, it is coming from intermaxillary segment. Now the secondary palate, again the secondary palate, it is paired structure. It forms the major portion of the palate. It is being formed by the secondary palate, and this develops from maxillary process. So here this is the maxillary process. From this maxillary process, the two shelves, they go and they meet. So they are forming the secondary palate. Now here in this diagram to the top, here it is seen, go to the previous one slides, the basic one. This is the nasal pit. Around the nasal pit, the frontonasal process is being divisible into the lateral nasal process and the medial nasal process. Now, another diagram which is showing the lateral view of the developing embryo. Here in the middle, here there is a nasal pit is there, a depression. Here to the top, there is lateral nasal process, and lateral to the pit, sorry, it is a medial nasal process. Now these nasal pits, it depends by invagination, and they form an sac which is called as ectodermal nasal sac. So this is here the red color shown. This is the medial nasal process which will be forming the intermaxillary process, which is separating the above sac, that is ectodermal nasal sac, from below the primitive oral cavity, both being separated by the intermaxillary process derived from the median or medial nasal process. Simultaneously, here it can be seen the the medial nasal process, it grows forward. Now, as the maxillary here, the maxillary yellow color, there's a maxillary process, it grows ventromedially. Okay, so the medial nasal process, they are brought close to each other. The medial nasal process start to merge. Here the two processes here can be seen. The medial nasal process, they merge not only on the surface but also on the deeper aspect or dorsally, and they will be forming the part which is called as intermaxillary process, which is very important. Now here the intermaxillary process is there, that is intermaxillary segment is there. This segment, it has got three parts. To the top, the first one anteventrally, this is the labial part which will be forming the philtrum. The middle part, that is upper jaw component, which is holding the 4 incisor tooth. And dorsally, there is another last part which is the palatal component contributing to the palate, and this is forming the primary palate. So these are the three derivatives from the three component of the intermaxillary segment derived from the medial nasal process fusion. Now, here by the end of 7th week and the beginning of the 8th week, the floor and the posterior wall. Here this is the ectodermal nasal sac is there. So this is the floor and the posterior wall which is formed by the intermaxillary process, the posterior part. Okay, this will get thickened to form a plate which is called as nasal fin. Now later on, these fin or nasal fin, it thins out to form oronasal membrane, which finally it ruptures, through which the nasal cavity, it communicates posteriorly with the pharynx, and this communication, it is called as primitive or primary choana. Okay, or posterior, these will be forming future posterior nails. Now the floor, so floor at this stage, it is consisting here in the diagram D, it can be seen that the floor of the nasal cavity at this stage, it is formed by the extension, that is extension of intermaxillary process, that is forming primary palate, which will be contributing to the development of the palate. Thus the primary palate is formed from the intermaxillary segment. Now, this is about the development of the secondary palate. Now, during the 7 to 8 week of development, a pair of thin wall extension, that is here it can be seen. This is the inferior view. This is the maxillary arch. Now, from the inner aspect of the maxillary arch, two shells, that is the thin walls are there, which are extending, passing medially and downwards. So they will be forming lateral palatal shells. So these shells on either side coming from the maxillary process, they are called as lateral palatal shells. At first, in this diagram, this is a coronal section. This is the inferior view. In the coronal section, here this is the developing primitive nasal septum is there. Now, here this is the from the maxillary process, there will be coming the palatine shells are there, which are the lateral palatine shells. And in the center, there is another, that is a developing tongue is there. So here important it is the palatine shells, that is the lateral palatine shells, palatal shells, they grow downwards and medially lying parallel to the lateral surface of the tongue. Okay, in the initial phase. But by the end of as further progress, they rotate rapidly upwards. Here it can be seen in the second picture, where in the first picture, the tongue is lying above, while the palatal shells, they are directed downwards, lying parallel to the lateral surface of the tongue. But with further progress, the palatine or the palatal shells, they rotate upwards into a horizontal position. Okay, position, and the tongues, it lies just below those palatal shells. Now, why it is important? The growth here, what happened? The mandibular process, there is growth and lowering of the mandible, which is very important for the palatal elevation as it lowers down the tongue. Unless the tongue goes down into the floor, the palatal shell, they are never going to come onto the horizontal position and they are never going to be fused, which is very important from the applied perspective point of view, where you'll be dealing later on. So the shells later on, they rotate, they lie in the horizontal position above the tongue and they fuse with each other, forming the secondary palate. Now here, the central region, here this can be seen, this is the hard palate. Now, yellow color, this is the primary palate, while coming from the intermaxillary process, while the orange color, this is the palatal shells coming from the maxillary process. Now, the primary and the secondary at the site, here, the central region of communication, there will be seen and foramen, and this is called as incisive foramen, which is a very important embryological landmark that decides whether the cleft palate, it belongs to the anterior or it is posterior cleft. Okay, so this incisive foramen, it is very important landmark. Now, these are the subsequent stages of the development of the hard palate, where the primary, this is the primary palate, these are the palatal shells, nothing but secondary palate. They come close to each other, they fuse to form, the primary and the secondary, they fuse to form definitive palate. Now these definitive palate, already it is membranous. Okay. Now the part which undergoes ossification, it will be forming the hard palate. You know, there is two palates, one is hard and one is soft palate. So the part of the definitive palate, that is ventral part, that is undergoing the ossification, this will be forming hard palate. And the unossified part of that definitive palate, which will be forming soft palate. Now, how to decide whether which part will be forming hard and which will be forming the soft palate? Here, it is determined by the attachment. This is a primitive nasal septum is there in the center, and it goes on and it gets attached to the superior part of the definitive palate. So the area which is where there is attachment of the nasal septum onto the superior part of the definitive palate, only this much portion of the definitive palate will be undergoing ossification. and rest of the part, that is the posterior most part, which will be not undergoing the ossification, as along the whole length of the palate, which is the septum, it is not attached along the whole length. That's why the complete ossification does not occur. Hence, the anterior part remains the hard one, that is hard palate, while the posterior part, it do not undergo ossification, so it will be forming the soft palate. Now, in the posterior part of the hard palate, soft palate, sorry, the myogenic, the mesenchyme, they condense to form the musculature of the soft palate. So the muscle there will be derived, which will be innervated by the vagus nerve and the trigeminal nerve. Now move on to the molecular regulation of the development of palate. So how they are governed. Now the first one. In this slide, even before the neural crest cells are formed, or even prior to the migration, the neural crest cells, they are formed at the neural folds. We know that. So before these neural crest cells, they are migrating, or even in absence of the neural crest cells, there is formation of endodermal pharyngeal pouch. So on the inner aspect, so these are the pharyngeal arch. On the inner aspect, this is endoderm, and this deepening between the two arch, it is called as pharyngeal pouch, endodermal pharyngeal pouch. So they are formed before the neural crest cells, they migrate, or even in, they are not present, even in absence of the neural crest cells, these endodermal pouch are formed. Now, how these endoderms, these endodermal cells, basically, they form the pouches through the lateral migration, and these migration is stimulated by a transcription factor, which is called as fibroblast growth factor. Okay, so this happens. Now here, this is developing embryo. This is the diagram showing the P1, P2, P3, and the P4. These are the pharyngeal pouch, which is lined by the endoderm. Okay. Now, these endoderm, they will express the different genes. Characteristic pattern of genes is being expressed. So ventrally, or sorry, the anteriorly, that is the red color it is shown, there is expression of a genes, that is red color, that is fibroblast growth factor. They are expressed in the anterior part of endoderm. Okay. Posteriorly, the blue color one, this is here the posterior part of the endoderm is expressing, or this is bone morphogenic protein 7. It is expressed on the posterior part of endoderm, while the dorsal most part of the endodermal pouch, where there is PAX1 gene, it is expressed, that is paired box gene. And the last one, in the third and the fourth pouch, there is expression of yellow color. The genes are there. So these endodermal cells shows the expression of genes, that is SHH, sonic hedgehog genes. So these are the different genes are there. A characteristic pattern of these genes is being expressed on the endoderm. And why this is important? These genes, they regulate the differentiation and patterning of the pharyngeal arch mesenchyme. So they bring about the differentiation of that mesenchyme into the specific skeletal elements. So this is being done by these genes. Now from here there is a bone morphogenic protein. This transcription factor, it does two important things is there. So on to the right, there is a figure. This is a neural plate is there. Here there will be forming the neuroectoderm and the surface ectoderm will be meeting, and this fold it is called as, the red color it is called as neural folds are there, where they will be forming the neural crest cells are there. So this bone morphogenic protein, that is BMP protein, what it will do, it will establish the edge of the neural crest cell. So it will help to forming the edge of the neural crest cells, where the neural crest cells will be forming. And the second one, WNT, these WNT1 gene, it is expressed, which causes the neural crest cells to undergo the transformation from the epithelial to mesenchymal transformation. So these neural crest cells, when they migrate to the pharyngeal arches, they undergo a transformation into the mesenchymal cells. So such transformation is brought about by the WNT1 expression gene. This is regulated by bone morphogenic protein. And also this helps in migration of these neural crest cells into the surrounding mesenchyme. So this is done by the bone morphogenic protein. Now, the next part here, the figure it is showing mainly, this is the developing embryo, this is the forebrain, here it is the midbrain, and behind there is a hind. So there are the different things are there, R1, R2, R3, R4, and so on up to the 8. Now these hindbrain, it shows the different segments, and each segment it is called as rhombomeres. So these are rhombomeres, each segment they will be having the neural crest cells. So these neural crest cells, they migrate from this region to the P1, P2, P3 and P4, P6, nothing but these are the pharyngeal arch. And here it can be seen, these neural crest cells, they are migrating in the 3 streams are there. That is blue color, the first, second, yellow and the green one. So these are the 3 streams are there in which the neural crest cells, they are migrating to those pharyngeal arches. Okay, so the neural crest cells from the region R1 and R2, they will migrate and they will occupy the mesoderm or the mesenchyme of the first pharyngeal arch. Now the neural crest cells from the R4, they will migrate and they will reach the second pharyngeal arch, while those from the R6 and the R7, the neural crest cells will be migrating and they will be occupying, that is pharyngeal pouch 3, that is P3 and 4 to 6 as the fifth pharyngeal, that is the fifth one, it will be disappearing. Okay. Now the neural crest cells, they migrate and they populate the arches, and where they will be forming the skeletal components, which is characteristic of each arch. And these process of these migration from this hindbrain, the neural crest migration, it is done. It is under the inductive influence of the endoderm, of those formed endodermal pouch. Okay. Now, the neural crest cells, okay, they are lying, which are present in the R1, R2 region. Okay, here it is shown blue in color, that is OTX. So these neural crest cells, they will be showing the expression or specific gene expression, that is ortholendric homebox gene 2. So these R1, R2 zone jo rahega, the segments will be there where the neural crest cells will be negative for the homebox gene, but they will be positive, they will be having OTX gene. So such cells, they migrate to the first arch. Now from the R2, that is, R4, that is the neural crest cells, they migrate carrying the homebox gene A2. So this such cell, they will be having expressed genes, that is homebox A2, and they will be migrating to the second, while those neural crest cells from the 6 and the 7 will be having the genes, that is homebox A3, B3 and the D3, and they will be migrating onto the pouches 3 and 4 to 6. Now, why this expression of the different transcription factor it is important? They allows each arch to respond differently to the signal from the endoderm, such that the first arch will be forming the maxilla and the mandible, while the second arch will be forming the hyoid bone. While the one more thing forgotten, the neural crest cells from the R3, R5, these cells, they do not migrate, but they help in forming the 3 zones from which the neural crest cells, they are migrating. So we are finished with the pathway of this neural crest migration. Now move on to the development rectal applied aspects. Now, what is cleft palate and what do you mean by cleft? So there is 5 processes basically: the frontonasal process, median nasal process, a pair, and a pair of maxillary process, a pair of mandibular process, and the frontonasal process, which will be dividing into the lateral and the median. Now, if there may be the complete or the partial failure of the fusion between any of the above process, that will result in cleft. So the cleft, it may be unilateral, it may be bilateral, and it may be a component of 300 plus syndromes. So we classify those cleft deformities into the anterior cleft deformity and the posterior. So the landmark which divides or which differentiates between the anterior and the posterior, basically it is a incisive foramen. So whatever that is present anterior to the incisive foramen, it will be anterior cleft deformities, while posterior to it will be posterior cleft deformity. So the various deformities in the anterior cleft, they are lateral cleft lip, only involving the lip, cleft upper jaw, and cleft between the junction of primary and the secondary palate. The posterior cleft deformities, it includes 2 deformities. The first one, it is the cleft palate, and sometimes the cleft uvula only. Now, the anterior cleft deformity, what is the basic cause? As we have seen, the upper lip, it is formed by the fusion of maxillary prominence and the medial nasal prominence, one or both sides. So whenever there is lack, maybe the partial, maybe the complete lack of fusion of that maxillary prominence with the medial nasal prominence on one or both sides, it will be resulting in that cleft. While the severity, if we see the severity, it may be the mild and maybe the severe. In mild cases, there will be just a visible defect will be there in the vermilion, which will be extending up to the nose. While in severe cases, it involves the upper jaw, where the maxilla is split between the incisor tooth and the canine tooth. So this is the first photograph to the left. This is a diagrammatic photo from the embryological pictures, and this is a line. So this is a lateral cleft lip where it can be seen. This is the lip is there where there is a cleft is there. So it is involving only the lip. So this is called as lateral cleft lip where it can be seen. Second one, cleft upper jaw. So here there is a jaw is there which will be holding the tooth. So here it is seen a cleft is there. So this is the segment which will be holding the incisor tooth. From here begins the canine. So there is a defect is there, there is a cleft is there. So here the picture can be seen involving the cleft of the lip as well as the alveolar arch. Now the cleft between the primary palate and the secondary palate. So here this is a dotted line showing the fusion between the primary ventrally and this is the secondary palate. So sometimes there is failure of fusion of these two part, that is primary palate fails to fuse with the secondary palate, resulting in the cleft between the primary and the secondary palate. Now posterior cleft deformity, there will be a lack of fusion of the palatine shells, mainly the secondary palate. So it ranges from involving the entire secondary palate or it may be involving the soft palate only. So this is a picture of the cleft palate. Here it can be seen. So this is the hard palate. Behind these are the uvula. So it is involving in the entire palate. So this is cleft palate of the hard and the soft palate. Now here, this is the posterior part that is which is forming, that is the soft palate. Whenever such cleft is involving the soft palate, here it can be seen the two uvula being separated only involving the soft palate. So this is called as cleft uvula. Now what is median cleft lip? Now median cleft lip, the two median, there is failure of fusion of the two median or medial nasal process, which will be forming the two globular swellings. Defect, it will result in median cleft lip. Now, sometimes such abnormalities will be having additional, there may be cognitive impairment, brain abnormalities, and also the loss of midline structure where the two ventricles, they will be fused. So such picture it is called as holoprosencephaly. Now, also these cleft lip and the palate, they are associated various other syndrome, more than 300 plus. We are seeing some of the fews. The Van der Waals syndrome, this is the most common syndrome with which the cleft lip and the palate is associated. So it is autosomal dominant inheritance. In this picture here can be seen, there is a cleft lip is there, while the lower lip, it shows some pits are there. So this lower lip bearing the pits along with the cleft lip, such combination, it is called as Van der Waals syndrome. Now, it is also associated with secondary consequence of mandibular dysplasia, as we have seen that the development of mandibular process, it is important as it grows and moves down, which will making the space for the settlement of the tongue, which allows the hard palate to move, to rotate up, and they being close to each other and finally they fuse. So this, whenever there is mandibular dysplasia, what will happen? There will be a small mandible, that is micrognathia, ultimately resulting in the tongue will be falling backward, that is, or slightly it will be falling back and up. So this is called as glossoptosis will be there, which will be obstructing the elevation of the palatal shelves, lateral palatal shelves. So they become the part of Head-and-Toink syndrome, Pyre-Robin syndrome, Stickler syndrome, and the Treacher-Collins syndrome. So there is failure of fusion of these palatal shelf resulting in cleft palate. So these are the few references from which we have prepared this topic that is given. And thank you for listening and giving the opportunity to being here.
Great. Thank you, sir, for such an elaborate talk. I request our chairperson, Seema ma'am, and Dr. Shweta ma'am to please conclude and give expert comments. Seema ma'am, Shweta, you can start talking. In the meantime, I'll call madam to unmute because I think madam is there.
Seema ma'am, are you there?
I'll give her a call. You can talk in a minute.
Okay. Excellent talk, sir. I think so. You covered all the points exhaustively, and it almost felt like going back to MBBS days. So I think so. It was a really academic treat for everybody going in depth of the issue of cleft lip and palate. And I'm sure with this knowledge, definitely gynecologists can better counsel their patients regarding the prognosis. Thank you very much, sir.
Thank you everyone. Okay.
Dr. Seema ma'am seems busy. She's here.
No, ma'am is there. I spoke.
Seema madam, the first lecture of sir on embryology is over. So you
over,
have
ma'am.
few comments.
Yes. I think we are not able to hear what ma'am is speaking, I think. So,
Madam, can introduce the second speaker.
yeah, can we move forward with our next academic talk?
Sure.
Yeah. Harsha, can we have the slides, please? Yeah. Thank you, Wasim sir. Thank you for being there for all obstetricians and gynecologists. I'm sure many of us have taken a lot of take-home messages today.
Thank you, ma'am. Thank you. Thank you all.
Thank you, sir. Thank you.
Yeah, hi. Can I introduce the next?
Yes, Preeti, please.
Sorry, there was a urgent call. So thank you. I think Dr. Wasim, that was a fantastic talk and we really learned a lot today. We'll start with the next session. We have with us the chairpersons, Dr. Seema Porwal. Dr. Seema Porwal is the president of Islampur OBGYN Society and has been the proud recipient of the award of the best medium branch IMA Maharashtra for the year 2019 and 20 and is practicing in Porwal, Islampur since 1997. Welcome, madam. Next slide, please.
Thank you.
Next slide, please. Yeah, thank you. Dr. Vaishali Chaudhary. Welcome, Dr. Vaishali. She's the president of the Jalgaon OBGYN Society and has been the past secretary as well as the VP of the Jalgaon Society. Again, practicing since 2001 at the Siddhivinayak Hospital at Jalgaon. Next slide.
Present.
Yeah, thank you. We also have with us Dr. Manish Naigaonkar. Dr. Manish is a president of the Kolhapur OBGYN Society and practicing since last 29 years. Welcome all esteemed chairpersons. Can I please request Dr. Seema to introduce our next speaker, please? Dr.
Good
Seema,
evening,
ma'am.
Yes, ma'am.
Good evening, everyone. Thank you for inviting me as a chairperson for the session. We have Dr. Vittal Lahane. He's a MCH plastic surgery at Lahane Hospital, Latur, Maharashtra. He's the first plastic surgeon to start plastic surgery and burn care center in rural area, Latur. He's well equipped with exclusive 50-bedded setup for burns and plastic surgery unit. And he's presented many papers in national and international congresses. His center performed about 10,500 plus cleft lip and palate surgeries free of cost in last 20 years under Smile Train project at Lahane Hospital, Latur. He performed highest number of rhinoplasty surgeries in India, and he's delivered more than 2,500 motivational lectures for young generations, and this is his hobby to guide young people. Welcome, sir. Welcome to the talk.
Thank you so much. Asha,
Please allow sir to share his screen, please.
He's allowed screen share.
Yeah.
Yes, Harsha.
So you'll be able to share. You'll be able to share your slides, sir, or if Harsha is sharing.
Yeah. Okay, fine.
Yeah.
Sir, down there, green share button.
Yeah, I already shared my screen.
Yes, it is visible.
Yeah. So I will not take much time. I will be speaking only.
Sir, the PPT is not open, sir. We can show. We can see your window, sir.
PPT.
So share screen, and you have to open the PPT before you start sharing your screen, sir. Then you can make it as a whole screen.
Yeah, that is what I'm doing.
Yeah, yes, sir.
Okay, can you see this?
Yes, sir. Now it is visible. Now we need to make it full screen, sir.
Yeah, I will do that. Can you see this?
Yes, sir. Yes, sir.
Okay, but I can't see other people's face. Okay, coming to my talk. I'm going to talk about the bridging the gap in the cleft care, the power of surgery partnership. So this is a small talk, maybe not more than 15-20 minutes. Basically, what is the ideal management in the cleft lip and palate deformities? Ideally, one should have a counseling when the baby is in utero. Assure the parents it is a treatable anomaly. Your child will be as normal as other children with the timely surgery and necessary treatment. In counseling, we have feeding, pre-surgical orthotic, cleft surgery, palate surgery. I mean, this is a protocol, ideal protocol, speech therapy, post-surgical orthopedic management for the alveolar bone graft, then alveolar bone graft surgery for the abdominal treatment in maxillary retrusion cases, correction of post-cleft lip nose deformity at around 18 plus, scar revision, touch-up surgeries, and this above mentioned treatment will be required for expected result. But what is the problem? Let me tell you, we have started our practice at Latur in April 2000, and when almost 25 years ago. And we have started celebrating the anniversary of our hospital with the cleft lip and cleft palate surgeries. But to my surprise, this is the number of patients they came down to me. A huge number, and at any age. I came with some ideology that the cleft lip is to be operated by 3 months of the age, palate by 1 year of the age, and these are the patient came to me for the free surgeries. I don't understood what to do with these cases, but you know, this was the fact about the cleft already mentioned. But let me tell you that what is more important, the last sentence, 90% cannot afford the cost of surgery. That was the main concern why these people, they are carrying the deformity of the cleft lip and cleft palate for maybe 40 years, 50 years, 60 years, like that. So these patients are really in the need of surgeries. These are the poor patient and couldn't afford the cost of surgery. These services were only available at my time in metro or the tier 1 city. So just operating once in a year, that is on our anniversary days, will not solve the problem. And we are not in position to provide free surgeries to these poor patients. The reason, basically, I am from very poor family. Not a single bank was ready to give me a loan to start my hospital because I was not having any property to mortgage in the bank. So I wrote the Smile Train about I need to please help me out. And Satish Kalra from Smile Train asked me, where is Latur? Which airline operates at Latur? And I tried to locate but couldn't understood. Finally, I told him the earthquake place, and then he said, oh, yes, I know. So Mr. Satish Kalra was a humble human being, and he came to Latur in 2004 and got the partnership with the Smile Train. The major problem in bridging the gap in cleft care was solved. We started doing free cleft lip and palate surgeries throughout the year under the Smile Train project since 2004. So this was the main concern for the free surgery for the unaffordable patient. The main problem, the main gap was solved. But what is more important now, to make aware about this free treatment, the cleft lip and cleft palate is treatable, that to free of cost. Identifying these patients and bringing to our unit or any unit which we operate on this patient is the main concern issue. Initially, we worked with the Sarva Shiksha Abhiyan in Maharashtra. We wrote to them about the free surgeries of the cleft patient. They are personally used to identify the patient, collect them, and send them to our hospital. This is how the patient came from almost every district, from Amravati, Akola, Buldana, Wasim, Nandurbar, Jalgaon, Sambhaji. You name the district, we almost 29 districts they came down to our hospital, 29 districts in Maharashtra. And we started doing these surgeries on every Saturday, Sunday, almost for 10 years. So these are the kind of camp, and this is one vehicle Smile Train has given to me, is a nano car. It's only for the awareness. I do drive this car. I really love this to drive and go anywhere in nearby places. So this is how we do awareness in school. See, this is what you have read about. I have a hobby of guiding the student. I deliver almost 200 talks in a year for these guys, these students, and this is that has helped me. I go to a school, college, everywhere, and I talk about this. So identifying the patient and setting them bed, it was a bit easy to me, and I made a team. The problem with me was, I told you, I'm from a very poor family, and nobody was ready to give me the loan to start my hospital. And you know, I was doing this charity work with the Smile Train, and whenever I put some assistant, the assistant was not ready to work with me for him the next year. They asked me to increase my salary, so I added a team member to my team. Was my wife. She's a dentist. Everybody will agree with me to adding a assistant as a wife is very difficult, but I'm very lucky to have. And she assisted me, my analysis partner. This is a great team. We made it, and we started working this. But now, what we are doing, we are training the most important part. That's the first ASHA worker. First health worker is the ASHA worker or RBSK worker. In Maharashtra, these are the people in every district. They have almost more than 1,000 in every district. They are more than 2,000 in bigger district. So, and they are the first-hand health worker. Every patient from every small village, they are aware of it. So what we are doing is now with the Smile Train and with the Bajaj Finsur, we are conducting camp like this. We are training them in every district, right? So these are the number of ASHA workers. They come, we train them. What do we train them? We tell them this is a treatable anomaly. This is a free treatment, and we show them the pictures how the pre and how the post patient can be look like. So and we made them avail. And second thing, I always give a priority. If some patient come to me and if the patient says ki ASHA has said, so that patient will be the priority. So ASHA will give more power. Okay, they are good, recognized the hospital. So this is how we do it. We teach them how to feed. First is the counseling, assurance to the parent. Second, feeding part. Third, at what age the primary lip can be operated, at what age palate can be operated. If there is a problem, we also treat this patient also free. We give them nutrition, the pediatric guideline, everything is free of cost. So just what they need to do is just identify them and send to our hospital. That's all about. And these kind of training are going on now. And we trained almost more than 5,000 ASHA workers. And they are the people, they are sending the patient. And Bajaj Finsur, Smile Train, they are supporting us for doing these programs. We give them the bag, we give them the food, we also provide them the travel so that they come and attend the program. And now this ASHA worker, RB workers, they are supporting, and we are providing this with the Bajaj Finsur and the Smile Train. Working on this issue consistently 10 years, and now scenario has changed. We have now 1 to 3 patients in a week with the sonography in the hand, having baby with the cleft lip or cleft palate. And this is the sea change. This is something I wanted. Really, I was thinking this condition must come in a day, sometime, rather than the patient coming to me with the 40 or 60 years of the age, the cleft lip palate. The ideally patient should come with the sonography report, and this is what is happening now. And this is something very really important with our partners. These are RBSK partners, and these patients are getting the excellent result. You know, if you operate the lip at the age of the 3 months, the palate before the age of 12 months or the 18 month max, they have got the better speech, the normal speech. They look normal. They will not hide themselves from going to the school, and they will be the better part of the society. You can see their smile and they looks too good. Only thing, they should come to the hospital, to the partner center on time. So timely treatment is the most important thing in getting the best and best results. So these are the things that are happening. These are the patient, they come to me, and always mother is worried about the baby. Always they worried about the baby, and they come to me in the consultation, and they always cry. See, sir, God has given me baby like this, and I operate them, and at the day discharge, I always call mother and ask them, then who this baby belongs to whom? And then the way they smile is the great answer, and that's the great power to me, energy to me to operate and work more and more on these patients. So see, this is how we have a good number of patients we operate. Almost every day we operate minimum 2 to 3 cases. So our unit is doing a great job on these particular cases. So, but still there are so many patients even today. They come late. What is my advice? Even for everyone, even today the gynecologists, they are there. There are so few other people, they are there. My advice, these patients should come as early as to the hospital, and they will get the primary treatment. They will be as normal as other children in the society. So you can see Cleft, our unit, we perform 500 plus Cleft surgeries every year, and till date we have got 10,500 plus surgeries. So we have almost 29 districts we have drained till date. So coming to the last point of our conclusion of my talk, only thing, the patient should come on time, and I am very happy, and I am telling you, these patients they are coming not only from the one part of the second part, they are coming through the ASHA worker, through our RBSK worker. through all gynecologists, through all medical officers in the government setup, even all doctors from private setup. So this is the work, combination of the work, and I'm very extremely happy that Smile Train is supporting on this issue. So thank you so much. Done.
Thank you, sir. Such an inspiring story to hear from you. And kudos to the amazing work that you and Smile Train have been doing over the last year, sir.
Yeah.
These figures speak for themselves. I would request the chairpersons to please, Seema ma'am. Yes, ma'am.
Thank you, sir.
Dr. Vaishali ma'am. Yes, ma'am. Yes, ma'am. Both of you can please give your
We heard
expert
really an
comments.
inspiring story, and we are very proud that a member like you is working for
Ma'am, we can't hear you.
Your voice is not very clear, ma'am. It is breaking.
Thank you, Lane, sir. Now can we hear you? Hear me?
Yes, ma'am.
Yes. Thank you, sir. It was really nice hearing you and your inspiring story. We are proud that we have a member like you in our society. And you are doing so much for the people of Cleft and palate. It was in the village, sir.
Vaishali ma'am.
I don't see Vaishali, ma'am. Yes,
Vaishali. Yes, ma'am.
Inspiring, and I express my sincere gratitude to the whole team, which involves right from surgeons to the volunteers, which tirelessly restore not just the smile but the future of the child also. Thank you.
Thank you so much for inviting me for this particular webinar. I'm really happy, and and the gynecologists are the main person in referring the patient. So I always thankful to the gynecologist, and I have a great association with the all gynecologist people. They are really good people because they are the person who usually tells the parents this surgery is possible, that is free surgery, and this child can be as normal as other children. This is something that these words at time of delivery is something great for the parents, and that is what with these words the patient come to me, come to us, our center, our different centers, and then they get rated. Only my advice and my I'm working on this last 25 years now, and I'm with the Smile Train 21 years. I'm working every day 2 to 3 surgeries, and we are extremely happy. Only the sea change what I've seen. I entered in Latur in 2000, 25 years ago. I could see the patient with the 40 years, 50 years, 60 years. I was really bored. But now I can see the patient with the sonography report in the hand. So this is what I thanks to Smile Train, and thanks everyone who is helping me out in this process. Thank you so much.
Thank you, sir. Now there's a question for Wasim sir in the chat box. That if there is a cleft which is diagnosed prenatally, do we automatically need genetic counseling and further genetic testing, or what are the chances of having an isolated cleft lip, cleft palate without having any other genetic defect? Wasim sir, please unmute yourself. Sir, you need to unmute.
Okay.
Yes.
Okay. So we have given the number of possibilities are there, whether both the parents affected, one parent affected, having a further child with unaffected parents. So these combinations and the risk of those offsprings, the percentage is being given. So with doing the counseling for the next offspring, care can be taken.
Your question is only concerned pertaining to that, ma'am? That is what you want to ask?
Yes, sir. So if there is an isolated cleft lip, cleft palate finding on the ultrasound, do we further go in for genetic testing?
even though you go for genetic testing and in isolated Cleft palate, there is no need to go for any genetic testing. That is first point. But if you have got associated some anomalies, which anomaly, major anomalies, yes, of course you need to go for it. But isolated Cleft lip or palate is a treatable anomaly. There is no indication for anything to go. I mean, no abortion or nothing, no termination. So for
Yes,
this, you need not go for directly genetic counseling or genetic testing.
okay, sir. So then, what are the essential barriers that you have identified in your practice that prevent people from coming for a treatment for cleft lip, cleft palate, sir?
Good question. First is negligence and awareness. I can see even today, ma'am. Let me tell you, I have got 1,500 plus surgeries. Means to me connected minimum 10 lakhs people. 10 lakhs people connected to only one person. I'm talking about 10 lakhs people only involving the cleft, right? So anywhere you go, I have one or two my patients or their relatives, and they are my brand ambassadors. They refer a patient to me. Even though telling the patient's parent repeatedly, you need to treat this child, but they just neglect sometimes. They are unaware the side effect or the major problems in future. Major issue is the speech. Major issue is the speech. Okay, even though lip you operate late doesn't matter, but you need to operate palate as early as possible before 18 months. That is ideal time, and you will get 100% normal speech. This is something really important. Otherwise, now it's a child, but she or he going to grow, right? They need to go through the education, the services, their career, then again the marriage and so many problems. So if you really tell them repeatedly, this is something. Only barrier to me is the only awareness and negligence. There is no other barrier. We are ready to give them even the travel expenses. We are ready to give them the travel expenses. There is absolutely 100% pre-treatment, 100%. Nothing is required. Even pre and post, if you need something, that is also free. So where is the problem? Now we are making awareness everywhere. Madam Srikandi was telling ki people should be aware of this. Every person in a very small area, very small, even the farmer knew about it. This is a treatable thing, and this can happen because we put so many big posters everywhere. Okay, big photos and banners. So yeah, people are aware of it. Only thing they are not that much serious about it. So now our job is to make them very serious.
Sure, sir. Thank you so much, sir. Harsha, I think the third question that you have put in is regarding what is a gynecologist role. Almost all of us understand that there are two main queries as a gynecologist for a cleft lip, cleft palate baby. First is the concern that the mother has is the physical appearance of the baby, which I think sir can take care of. And the second, which we are more worried, is the feeding in the first initial 6 to 7 months before the baby is operated on. And so, appropriate counseling from our end as a gynecologist for feeding these babies will help them in long way to at least develop a little amount of weight. So then they could be projected to anesthesia and carry out the surgery as more safely. I think that is. Yes, sir. Yes, sir. Yes, sir.
As far as breastfeeding is concerned, you can breastfeed the baby every lip or palate. There is no issue at all. Only thing they worried. I always tell mother, that your baby has a lip or palate, but baby doesn't know what she or he have. Okay, you worried, baby doesn't worry, right? So feed it, but only position. We have one smile train video. I will share with you now in a minute. Okay, I will share with you that video. Now what I am doing, every cleft lip palate coming to me early means in pregnancy or something, we give them that video and see how we can feed it. But now you are the very highly learned people. I will let you tell you, you can feed the cleft lip palate baby as normal as other babies. So there is no problem in feeding the baby. Only thing, if there is a bilateral cleft lip palate, and just holding the nipple is difficult. In that case, what I suggest, you always ask mother to keep your baby or let the baby suckle the nipple for some time. Then the mother will get a good amount of milk, and then she can express the milk and feed. Even we have feeding tools as well, a different spoon, how to feed. So I can just share a video with you, but please guide them that every baby can be normal breastfeed. Yeah.
See, can I ask one question, Monica?
Yes, Supriya ma'am.
Yeah. This is actually for Lahane sir and Leela ma'am also.
Yes.
Can we share the toll-free number to ANC patients?
Yes,
If
please.
they call, will they be properly entertained right away?
Yes, in fact, we have 3 Cleft helpline officers who sit in Delhi, and we take in every call, and we speak to the patient, we guide them, and we refer to the closest hospital. So what Dr. Lahane was saying is like, if you see Smile Train supports, besides the surgery at the hospital, Train supports the travel of the patient, the nutrition of the patient, speech, orthodontics, everything is supported by Smile Train in their partner hospital. So like I just
Okay.
wanted to add, like, the airway of the children who are born with cleft is compromised. So we have a nutrition program which has been spearheaded by 2 nutritionists from the medical colleges in they are an advisor in Chennai and in Lucknow. So we have been doing a lot of webinars. In fact, Dr. Padmasani was in one of your webinars also. So we
Yeah.
have a lot of webinars, basically, promoting the first 100 days, the importance of 1000 days in the child of the light for the cognitive growth for the child, and the importance of the mother's milk. And besides that, under a nutrition program where the mother cannot lactate and the child is, so we teach them about them we counsel them, the nutrition parent, the caregiver, on the feeding, the hygiene, how to express the milk, how the milk is to be stored. Like we recently had a case in one of the good hospital over here, one of the, big large cities. The child was admitted absolutely dehydrated because the mother was giving diluted animal milk formula. So wherever we possible, we tell them. So we are providing the formula feeds also. So we do give because formula feeds, what we have seen, they are fortified, and if they have to be made, the mother is taught how to make it, how to give it with the paladai or with spoon and all. We discourage, because in our today's day and age in the rural India, the mothers they have multiple roles to do with the families, so they are not able to sterilize that, the thing. So we encourage them, but the milk should be not, the bottle should not be given, how to sterilize. And we are giving, and in the case where the child is mother is lactating, we are giving the feeds to the mother also to increase, to boost her milk. We're giving the vitamins and ions to boost her, and sometimes the formulas also, which can, and even after the child is after 6 months or 1 year, we encourage them to give what is there from the family pot, from the kitchen pot. Like, and every region has got, there is a sattu, there is a nachni, the millets which are, good for, or there is a gur, there is a til, so instead of, telling them to have an apple a day or kind of a thing, we tell them, we encourage them, or everyone to have the local food which is regionally available and which is healthy for everyone. Food is which is seasonally and regionally available is more healthy for the child and for all of us. We've shifted to this, cold storage food, apples and all. Banana is so healthy, which is available everywhere in India. Gur, til, and all the. So we encourage. So we have a nutrition program running in about 40 partner hospital, where nutritionist, tells them how to, and tells them how to fortify the meals of the child also. After the child is 6 months old, how to add fat, monosaturated fat into their meals and all that. So we do all these things, and we support through the nutrition program. We give the food packets to the child as well as the mother under a nutrition program and because our main priority is to make sure the child is healthy and safe for the safe surgery. That will only happen if the child has got adequate nutrition. So that is one thing, we have been emphasizing of lately a lot on our nutrition program,
Yes,
because
ma'am.
a healthy child will have a safe surgery and timely surgery.
Very nice. Ma'am, may I make one request? If you can just give us a list of the hospitals that are under the Smile Train umbrella, since we are in AMOGs, at least in Maharashtra.
Yes,
We
yes.
can circulate that in our gynec groups. So even
Definitely we'll
people
do that.
who cannot attend some of these webinars, at least they have that information where to refer their patient.
Yeah.
Great.
So in fact, your slide was slightly outdated. We have 13 partner hospitals in Maharashtra now,
One is
and
at
in
Solapur.
11 partners, and in 11
Yes, ma'am.
cities.
So if we can just get that list, the
Yeah,
updated
I'll
list
send
from
it. I'll
your
tell
side.
Charvi to send the list to you.
Yes. Thank
Harsha
you,
shall
ma'am.
share the
And
list
ma'am,
with you.
Leela ma'am, there was one more request in case if all of us, any of us wants to contribute to this cause as Smile Train, Sir, where could we do it as a part of our
Great.
CSR?
So we have a website. You can do
Great.
it through our website. You can go to Smile Trend
Yes.
India and you can donate directly through our website. And
Thank you.
after you donate, you will
Okay,
get your
ma'am.
certificates, the whatever, that for tax rebate. We do all that. So you can go to our website and donate directly from there.
Sure, ma'am.
Mhm.
Okay. Thank you so much,
Thank
ma'am.
you,
And I
ma'am.
request Supriya ma'am to please conclude the program, ma'am, now.
Yeah.
Thank you, Dr. Monica.
So
Yes, ma'am.
I must foremost thank Dr. Kiran
Yeah.
Kurtakoti and AMOX team for taking this project forward on board with Smile Train, which gives us
क्या करते हैं?
week after week so much knowledge and so much of clarity as far as cleft lip, cleft palate are concerned. Please let me thank the speakers, Dr. Wasim sir. It was like anatomy
ये
class,
उसको बोल
just like
separately
one of
इसका
the
payment कर
chairperson noted.
हाँ उसको
It
बोल
was like
इसका
going
payment
back to
separate
first
कर
MBBS. Thank you for a very, very clear and lucid
clear
presentation.
accurate है
And Dr.
ये क्या कर
Lahane,
रहा
I
है
am falling short of words for the kind of work you're doing,
Light
sir.
to light क्या
Really,
है
it's honor that you are as a speaker in our session. It is our honor and pleasure to be interacting with you.
ये भी तो डालो
A big thank you to all
ये
the
visit fees अपना
chairpersons,
है
to
5,000
our guests of honor and chief guest, Dr. Amey Purandare, Lakshmi ma'am, Sujata ma'am, for making it convenient to attend. For Monica and Preeti for doing the entire legwork, all the hard work that goes behind this. And of course, Leela ma'am, Harsha, and the entire team of Smile Train for putting all of this together. Thank you, everyone, and looking forward to yet another episode in the future where we'll join in for more knowledge exchange. Thank you so much.
Thank you.
Thank you so much, Dr.
Thank you,
Supriya,
Dr.
Dr.
Wasim,
Monica,
Dr. Lahane.
Dr. Jha, and Dr. Vyas.
Yeah.
Thank you, Leela
And
ma'am.
Dr. Wasim
Thank
and
you,
Dr.
Leela
Thank
ma'am.
you. Thank you,
Thank you,
Shweta.
Leela
Also
ma'am.
doing
Thank
amazing
you,
work.
Wasim
Please
sir.
keep up.
Thank you,
And
Monica.
thank you,
I'm
Lade
so
sir.
glad to
Chalo,
meet
मिलते
Dr.
हैं.
Lahane. Really inspiring.
Really,
Thank
really,
you.
very inspiring. Very inspiring.
Thank you so
Thank
much.
you so much, everyone. Have a great day. Bye.
Thank you.
Thank
Hello,
Bye.
ma'am. Stay in touch.
Thanks, Harsha.
Thank you, ma'am.
Thank you.
Wasim sir,
Sure, sure.
thank you so much for accepting our invitation and giving us an in-depth knowledge. I think at least we would be able to interpret our ultrasound images much better after this.
Yes.
Thank you,
Okay.
sir.
Bye. Bye.
Thank you, sir.
Bye.
Everyone.